Thank you so much, Brian. It's a great privilege and blessing to get to be here with you all today. My apologies for bringing the southeastern tornadic weather with me. It seemed to follow me on the plane here. How many folks work or have worked in healthcare? Very good. How many folks have given some sort of care, assistance, or service to a friend, loved one with an illness or injury in the last year? How about in the last couple of years? Okay, so we all work in healthcare, right? It's just some of us get paid to do it, and some of us are probably paying out of pocket to do it. So the healthcare industry sometimes refers to you folks who are caring for your friends and loved ones as informal caregivers. I think that's one of the dumbest things I've ever heard. There's nothing informal about what you're doing, right? It's a blessing and a privilege, and it's work. So we wanted to talk a little bit today. These are some of the topic items that Brian and I talked about that we might cover today. But really, what's more important is why you guys are here and what you guys would like to hear about. So I wanted to have an opportunity to just hear a little bit about what you guys are interested in talking about today. Anything that's not on that list? And if you think of something later, we'll have a chance at the end to kind of chat as well. Yes?
The first time we winged it.
Okay.
I'm like, what do you think we should do? We didn't have as much structure or being able to know that we need some better.
And caring for someone with dementia?
Yes.
Yeah, so just kind of winging it?
Right.
Very, very common. Yeah?
So we figured some getting some structure if we can.
Okay, very good. So if we don't hit that specifically, be sure and bring it up when we have some discussion time. Yes, sir?
I'm interested in seeing how palliative care and hospice, what the connection is.
Excellent.
What the caregiver can do
Yes.
to make that happen.
Perfect, perfect. So we're going to cover that after the break, very specifically. That's great. Yes, sir?
I'm interested in moderate cognitive impairment.
Okay.
Particularly how it can evolve into dementia.
Okay.
What can be done to prevent it.
Perfect. Okay, I've got a slide on that. I guess it's kind of good there. Okay.
I work in hospice.
Okay, perfect. In what role?
I'm a volunteer.
Oh, great. Very good.
Anywhere from 2 to 3 people I visit weekly.
Fabulous.
And I'm currently working with someone with dementia.
Okay. So when we get to the hospice conversation, you can help teach all of us.
I doubt it.
Yeah, absolutely you can. Yes, ma'am. Did you?
I don't know if this is under your purview, because you're not really a social worker, but the financial and
Yes, absolutely.
personally and society.
Yes. I was talking about that at dinner 2 nights ago with a friend of mine. So we'll touch on kind of what I'm experiencing as a caregiver myself a little bit in that arena. So that's fabulous. So we all, you guys clearly got up in the terrible weather on a Saturday morning to come here for a reason. So I suspect many folks do have some sort of dementia story, such as working in hospice as a volunteer and caring for dementia. Does anyone have their dementia story they like to share? Yes, sir.
My mother was one of 7 siblings, 5 of whom had Alzheimer's.
Okay.
My wife and I were primary caregivers for 2 of them.
Thank you for doing that. And how did that impact you all as caregivers?
Well, in my generation, only one has had Alzheimer's.
Okay.
5.
Okay.
So are we getting skipped? We don't know.
Yeah, very good. Anyone else have a dementia story? Yes, sir.
I'm currently a caregiver to my wife,
Okay.
who has been on Alzheimer's medication for about 11 years. And I've seen problems before that
Mm-hmm. You said about 11 years?
Yes.
Yeah.
From there, that's like 5.5 years.
Uh-huh.
And then on the past, like on past, and remember, so about 5.5 years.
Right.
Currently is in a memory care facility where I live until we were out of town.
Uh-huh. Okay.
So I'm sort of the chief caregiver situation, father, whatever.
Fabulous. Thank you for doing that. So I work in healthcare, but I'm also an informal, formal caregiver. So a little bit about my dementia story, and there may be some areas that we share in common in this. So this is actually a photograph of my grandparents. I'm originally from Waco, Texas, and they worked at Baylor University for decades. So my grandfather was the director of the Armstrong Browning Library. You may have visited there, sir, when you were there. This is a photograph of them probably over 20 years ago, and my grandmother in that photo is already in her moderate stages of Alzheimer's disease. And this is in a time where even in the quote-unquote formal healthcare community, there really just wasn't a lot of recognition of the disease, a lot of underdiagnosis. There really wasn't any education provided to caregivers. I shouldn't say any, but not a lot. And so as her disease progressed, much like your wife's, it was very long, over about a 15-year period. And sort of she had, not every Alzheimer's patient will have all the same struggles, but she had a particularly difficult combination of almost every symptom and behavior you can experience. And my grandfather back then, really just, the healthcare system did not provide him the education, the support, kind of what to expect. And unbeknownst to us, he was not able to keep up with his cardiologist appointments and wasn't able to fill his prescriptions. And so things got to the point where my grandmother had to sort of emergently be placed in an inpatient psychiatric facility in town there because of some behaviors that endangered her safety and his safety and those types of things. And he had then just gone to the courthouse and signed the guardianship papers and got back home and was calling up his best friend to tell about this pretty horrific day he just had and died of sudden cardiac arrest. And I tell you that story because we're all in this together. And I wish he had had kind of that support system that is more frequent out there. That I was a medical student at the time, which means I knew absolutely nothing about dementia. They didn't even teach us about dementia as a medical student back then. So one of our passions at UAB is to provide this training and education and support, not just to caregivers, but to those who are paid to be the caregiver. So a lot of this material we're going to talk about today, we're actually training our own hospital staff in these same kind of knowledge and skills and techniques. My mother has just tipped into early Alzheimer's herself. So I'm now experiencing more firsthand being a direct caregiver. So flying back to Texas, going to the geriatrician's appointment, first of all trying to find a geriatrician, going to the appointment, hearing the bad news. You know, so I'm experiencing all the emotions. It's very different from being the geriatrician to the caregiver. So I can relate to some of your experiences, at least in the early stages, which is where we are now. So what is, anytime we have conversations about dementia, even at work, everybody in the audience is always kind of thinking about, oh my gosh, am I doing that? Do I have dementia? Is that me? And of course given my family history, which you've just heard, I'm doing that all the time myself. So it is very normal to have changes as we age, and these changes don't just start in the later years, they start kind of throughout the aging process. So it's very normal to just take a little bit longer to maybe learn or to recall information. So eventually the name comes to me, but I don't recall names as quickly as I used to. Some occasional forgetfulness. I have to fly to Texas in a couple of weeks, and I booked my flight for the wrong week. Okay, that doesn't mean I have dementia. It just means I'm kind of busy right now. Okay. I too, like if I don't put my keys in the same place every time, I forget where I put my keys. Okay, this is all normal stuff. We all do it. The key is that it doesn't progressively get worse dramatically. It's very gradual. And lots of things cause memory loss that can look like dementia that are not dementia. The most common thing I see is medications. So lots of medications out there can mimic dementia, especially sedating antihistamines like Benadryl. So anything with Benadryl, like I don't take anything with Benadryl. So in general, anything with diphenhydramine, anything that's a sedating antihistamine or anything over the counter that's a sleeping pill is basically Benadryl in disguise with fancy packaging and a higher price. That's all that is. So that drug alone can mimic dementia, can cause confusion and forgetfulness. But lots of common things, stress, lack of sleep, depression, anxiety, these things can all look like dementia. They're not dementia. And these things are much more common than dementia. Okay? So what is dementia? How can we distinguish between some of those other things and actual dementia? Well, dementia is a global term for changes in short-term memory or some other domain of thinking. So a change in memory or thinking that happens over time and can involve language, so word-finding difficulty, visual spatial skills, so kind of navigating objects in space, the ability to process information, so take in new information and kind of sort out the meaning, especially complicated information, judgment and problem solving, and impulse control. So these are kind of the characteristics of dementia, and folks usually have more than one of these, and they may come in different orders. The key to distinguishing between, well, I'm just busy, that's why I booked the wrong flight, to I actually have dementia, is that this is a change from my baseline lifelong functioning, either kind of socially or professionally. So now these changes are not transient, they're steady, they're progressive, and they're changing my ability to navigate life the way I used to be able to, okay? It gets worse over time, and Alzheimer's disease in particular is usually over years. And Alzheimer's is the most common. So the term dementia is kind of a global catchphrase for all those different changes in memory and thinking. Dementia has many different causes, and Alzheimer's is the most common cause of dementia. So I may say I'm having chest pain. That's a global term that explains a symptom I'm having, chest pain. My chest pain might be caused from heartburn because I ate a burrito, a heart attack, I might have a broken rib because I fell. So those all cause chest pain, but the cause of the chest pain is one of those different diagnoses. Does that make sense? So a common question I get is, what's the difference between Alzheimer's and dementia? Alzheimer's is a cause of dementia, dementia being the syndrome that is those changes in memory and those other domains of thinking. Does that make sense? Now, if someone has dementia, odds are it's Alzheimer's. The other kind of more common cause would be hardening of the arteries or vascular disease in the brain, and it usually is not so much a big stroke that you can tell someone's had a stroke. It's more tiny vascular disease. And probably the second most common cause of dementia is a combination of Alzheimer's and that hardening of the arteries in the brain. Does that make sense? So essentially, dementia is brain failure. So the brain is broken because of a disease process. So all of us, these temples weren't created to last forever, these bodies that we were given. So all of our bodies are slowing down sort of gradually throughout our lifespan, and eventually various organ systems will fail. So when a person develops heart failure, the heart is getting tired and weaker, and they might get short of breath. Okay? So when a person has heart failure, you won't see a doctor or a nurse go up to the person and just say, just get in their face and say, breathe better. You're not trying hard enough. You're not listening to what I'm saying. Breathe better, right? That would be ridiculous, right? But you will see in the healthcare industry, folks still struggle with the fact of going up to a dementia patient and saying, listen to what I'm saying. You're not listening to me. Follow me. Okay, their brain is failing like the heart is failing. Does that make sense? So it also does not make sense for a healthcare provider to just sort of say it louder to a dementia patient. So it's brain failure. So when you're out there with your loved ones, you may see some of that happening in healthcare and may, take some of the skills we talk about today. You may need to actually role model for folks in healthcare. So this is the type of training. We're trying to fix this problem out there in healthcare. Does that make sense? So the brain is broken. So in that situation, one of us has a brain that's broken and one of us doesn't. Which one of us has the capacity to sort of change our approach, right? The one whose brain is not broken. So in the brain is made up of cells called neurons, and these cells basically have cell bodies, which are like long, like trunks of trees, and then they have these what's called dendrites, these sort of spokes, like tree branches going out. And the way brain cells communicate is like the way these tree branches touch each other from the other tree branch. So messages travel from brain cell to brain cell across like these tree branches touching. Does that make sense? Like a squirrel going from tree to tree. In fact, it's exactly right, because there's actually a little gap called the synapse, and the message has to flow through chemicals across that little gap, like the squirrel jumping. I'm going to use that analogy. That's good. So if there's a disease process in the brain and the cells are dying, then the brain starts to look like this. So now you see the problem. There's no way for the cells to communicate because there's not as many of the cells, and they're not touching anymore. So in Alzheimer's or dementia, so I bet you never thought you'd see a picture of a brain in a church, but here you go, a brain in a church. One of God's most fascinating creations and complicated creations that we still cannot explain. Here it is. So the top picture is just a cross-section of a brain. That's a healthy brain. And the bottom section is an advanced Alzheimer's brain. And what do you notice? Just spaced, right? So you can see how that brain is not going to be able to follow complicated instructions. And it's not that the dementia person is not trying. It's just that there's not enough cells there to communicate information. So we talked about, so we're probably most familiar and can most notice memory loss. So you tell someone a story and a couple hours later they can't tell it back to you, or maybe they ask you the same questions. But what about some of those other parts of the brain that get affected? So one we talked about was visual spatial changes. This is your ability to kind of navigate space. So if you ask a more moderate Alzheimer's patient to fill in a circle like the face of a clock, this is a very classic Alzheimer's clock. They just cannot get the numbers all the way around the circle. And I've seen many patients say, I know that's not right, but they just still can't get the numbers all the way around the circle. And then sometimes they don't notice that it's not right. Okay, so I'm already experiencing this. I cannot park a car without somehow always ending up in sort of the left side of the parking space. And sometimes I cross over the line. I know I'm doing this, I just cannot get the car in the center of the parking space. Now, do I have dementia? No, because this is my baseline, okay? So remember, to have dementia, it has to be a change from your baseline. Okay, but that's an example of visual spatial, and I've totally given up parallel parking altogether. I just do not do it. So if a clock looks like this, and this is a quick test we do to help determine should someone be driving. Okay, so should these people be driving? For their own safety and the safety of others? No, probably not.
How about that upper right one? I mean, that's pretty close.
Yeah, so that's better. So that might be an earlier stage. These things also sometimes get complicated because as we get older, we may also experience changes in our vision. And then the combination of the two can be especially risky. Okay, so I work in a hospital setting. So this is a typical hospital tray where we do our darndest to make sure you cannot get to your food. Okay? This is why everybody loses weight in the hospital. First of all, we put you on what I call the cardboard diet, which is a low-fat, low-sodium, low cholesterol, which you're never going to eat when you leave, and really doesn't matter for 3 days anyway while you're in the hospital. And then we like freeze wrap it, seal it like it could go to NASA. This food tray would survive space, okay? So what do you notice about this food tray, and why might it be difficult to navigate if you have dementia? It's got too much on it. It's very cluttery, right? What else?
Things you eat are wrapped up and they're isolated.
It's hard to get to, and like I'm not used to all my life my food didn't have plastic around it. You know, do I eat the plastic? What is the plastic? Why is that there? Yes, sir.
It looks confusing.
It's very confusing. So we've hidden the meat with some sort of green garnish there. I don't know why we did that, but we did. And then I might have a little bit of arthritis, so I already have a hard time opening those silverware packages. So this is just a lot of information to process. So remember we talked about processing information. This is just too much information to process to be able to navigate. Even if you could see it, if your brain has trouble processing information. Plus, this is a new way to deliver food. So if I'm used to getting food, that's not freeze wrapped or whatever, then I can still process that information. This is too new. It's too different.
Can I ask a question
Yes.
about that?
Yep.
Is the arrangement of the food on the tray a problem as well?
Yes.
We often think of the main meal being
Exactly.
and all these accessories
Off to the side.
off to the side.
Yep.
So the rearrangement turns out to be a serious obstacle.
Absolutely. You're exactly right. And we're also not used to getting our those two are beverages over there. One's a juice and is that other one a hot coffee or a cold iced tea? I have no idea. And it's all covered up, so I can't see it. We're actually doing a little project on our geriatric unit at UAB of making sort of very visual, dementia-friendly food trays for our patients, and then kind of measuring, can they actually eat more? We think they can, but so we're looking at that in our hospital. Okay, so we said to be dementia, they have to be these changes: the memory, the processing information, the visual, spatial, the problem solving. That's a change from baseline functioning. So what does that mean? What are the activities you have to do to kind of navigate your day, navigate your life? What are the things that you guys do? Get dressed. Okay, what else? What are some complicated things? What did you say?
Make coffee.
Make coffee. Yeah. Yes, sir. Go to the restroom. Even more complicated. What's even higher level than that? How did you all get here? You drove here. Yeah. Yeah. So you've got to kind of be able to triage a complicated list for your day, right? We all just somehow got our taxes paid recently. That's very complicated. I can't do that. So these are kind of some of the typical things that we have to do to be able to sort of navigate life. You may look at this list and say, well, that's just a typical Saturday, right? I get up, I clean the house, I go to the grocery store, I do the laundry, I cook the meals. In the healthcare world, these things are known as the instrumental activities of daily living, or the IADLs. These are the tasks that tend to go first in dementia. These are the things that you will start to notice, or those of you who are caring for loved ones, you probably can kind of think back. Well, like with my own mother, she can very clearly say, she knows it, and she can very clearly say it started with managing the finances and the math that goes with that. And also a lot of difficulty more kind of in what you were saying, sort of trying to work through the process to get through what I need to get done today. She struggles with that processing. Now again, this has to be a change from baseline functioning. So I do not cook. That does not mean I have dementia. That just means when I do eventually develop dementia, no one's going to be able to judge if I have dementia based on whether there's been a change in my cooking. Okay? So this comes up a lot of times when we're interviewing patients and families and trying to decide if these changes that they're experiencing are dementia or one of those other causes. We've got to find things that folks actually did at baseline to be able to compare. So if someone never did the laundry, then that's, you don't want to sort of ding them for not doing the laundry now. Does that make sense? So the amount of things that I'm going to have to be judged on is smaller than a lot of people, because I can't parallel park and I can't cook at baseline. Okay, these are the more basic things that you guys mentioned as well. And these are the things that we've really been doing since childhood, so these go later in dementia. So the complicated things go first. These more basic things like bathing, dressing, toileting, transferring, getting up from a bed to the chair and walking, and eating. And eating tends to go last, okay, of all these things. So those are the basic activities of daily living. Very good question. It's more in that judgment and problem solving area. Do you have an example?
Yes, I'm going to pack these dishes up today because they're getting ready to move. But an ankle will take off, come back, it's still there. Things like that.
Exactly. So that's probably more in the mild stages. It could be that your loved one has forgotten that the plan was to pack the dishes, or she remembered but she couldn't figure out how to pack the dishes. And sometimes it's just really hard to kind of sort those things out. So I think in your book or at the back you might have a handout that lists those cognitive domains somewhere. The memory. Let me see what's in here. Or go back to that slide where we had the list of what dementia is. Actually, no, it's just the second page here. This page right here. Just the very second page in your booklet. There's like a list of those domains of cognition. We're going to watch a couple of videos. Let me see if I can. Oh yeah, how do I do that? I'll let you do that. So this first video is a woman with, this is Bessie. She's 87 years old, and she has mild Alzheimer's disease. She was just diagnosed 2 months ago before this taping. So I want you to watch her. It's about a 3-minute video. And kind of look for some examples of those different cognitive domains that are listed here, and then we'll just kind of chat about what you observe after we watch the video. So just about 3 minutes when this pulls up. While we're pulling it up, what questions do you guys have so far? Yes?
Is it challenging for professionals? We listen to information about baseline versus changes, and if someone has never been a detailed person, always kind of big picture, and has never been real organized in their thinking, and is that more challenging to diagnose than someone like me who's an accountant?
Have you met my father? Yes, I'm experiencing that right now. Yeah. So our job is to learn about what the person at their baseline did do, whatever that was, and then kind of go from there, and then ask if there's been any type of change in that. And then try to elicit, are there other reasons why there might be the change, such as depression, anxiety, a new medication, a new medical illness. And really dementia, sometimes it's a combination of sort of typical features from the history from the family and sort of ruling out other things at the same time. Does that make sense? So the less the patient sort of did at baseline, it's a little bit more difficult. But once you just really learn about who a person was at their baseline, then you can kind of go from there. So an example is because of the genetic defect in Down syndrome patients have a very high risk of eventually developing dementia. Well, that's a patient population that already has cognitive changes at their baseline. And so the key is you start with whatever that person's baseline was and kind of go from there. Yes?
What about someone has mentioned Aricept?
Mm-hmm.
Okay, and my dad is on that.
Mm-hmm.
And it doesn't, I know it's not to help him get better, but it's to keep him from getting worse.
Right.
But in talking with some other people he has diabetes as well.
Right.
And so I've heard, someone told me that it's a possibility that the dementia comes from the diabetes, in which case Aricept wouldn't do anything anyway. So why is he on that? And
right.
What do I say to the doctor to say, let's try something, let's take him off the Aricept, and is there anything else to take the place of Aricept?
Right.
That would, you know what I'm saying?
Yeah.
That for the diabetes part of it.
So when folks have other illnesses like diabetes, what's that overlap or that interaction. So the diabetes is a great example because it gets at that second most common cause of the hardening of the arteries. So people who have diabetes develop vascular disease, and that includes vascular disease in the brain. And so there's very likely a combination of things going on. It also gets to your question, I think someone had the question around, okay, well, what is sort of mild cognitive impairment and what can we do what can any of us do to prevent dementia or at least delay? I'm obviously very interested in that personally because I have 3 generations of Alzheimer's ahead of me. So because there's such a vascular component to it, it's really the same things as heart health. So it's exercise, manage your blood pressure, manage your cholesterol, heart healthy diet, and even exercise alone can be very beneficial even if folks are in their early stages of dementia. Just staying active can help manage some of the symptoms and provide some stabilization. Yes?
I understand that there is, at least in the experimental stage, various medications that are being prescribed, pre-dementia kind of things. Are you familiar with any of those? Did you have any reaction to that?
Yeah, that we were actually talking about this at a lunch yesterday as well. So the challenge has always been to study dementia. It's a disease process that goes over decades, and it's a challenging disease to study because you can't really predict who's in the preclinical stages who might benefit from a drug to prevent the disease, because that may precede the disease by 10 years. And then you don't know which of those people are going to tip over into actual dementia. So the newest area is to try to pick up people through fancy brain imaging who might have some of the same brain changes in the brain as someone who might eventually develop Alzheimer's, and then try some of the new experimental drugs to see if that sort of stops the process. So that's kind of the healthcare world has been trying to get at that for decades. And there's some new medications that try to get more at the inflammation piece that might be coming down the pike.
A follow-up question. Are you familiar with some of these discussions about electronic devices that are put on the head to electrify certain areas that may be helpful? Are you familiar with that?
I am not familiar with those. Yep. Very good. Oh, yeah, that's it. Perfect. Pardon me?
What about the intelligence of a each individual? Because I've been told on hearing various symptoms, and I would say, well, my wife didn't do that.
Mm-hmm.
Like the cooking. One day she said, David, I cannot cook anymore.
Mm-hmm.
And she never touched the stove or pot or
Mm-hmm.
something. And I was told, well, individuals with greater intelligence, and he was a chemist,
Mm-hmm.
do things that way. But when she decided to stop cooking, she never touched the stove.
Right.
When she said she couldn't clean because she didn't know if she cleaned the room or the whole house.
Right.
Stop.
Yeah.
And it was never, we had a gas stove, and she never turned it on.
Right.
Walk away from it. They were trying to tell me that reaction of people that are a little bit more intelligent than others, and I thought that sounded fishy.
Yeah, it's a great question. It's probably not related just specifically to intelligence, but each individual patient is going to respond to their own disease and perhaps some of the frustration that brings in a different way. So some patients will continue to try, and even though they're not able to figure it out, and some patients will just say, I know I can't do it, and I'm just going to kind of stop here. Yes, ma'am. Yeah.
A neighbor was an aeronautical engineer, a very smart guy, and he had, I guess, become caught mild.
Mm-hmm.
This is definitely progressing. But he was, neurologist, pretty said that he used to get up driving. He refuses to give up driving because he said, I can drive fine. And he very much on level about clients too. So,
Yeah.
so it's
Kind of person to person. Absolutely. All right, so let's watch Bessie. She's 87 years old. We're going to watch just about 3 minutes here.
The reason why I put those marigolds in between is to keep something out. Keep it where it is. This is my rhubarb, see? That's what it looks like. For this pie that I'm making, I use 4 cups of chopped rhubarb. The sugar, 3 little beaten eggs. We have a few pies left yet, pumpkin. She is my favorite. I was so glad I had that road down next to me for the happy one. Who was that? That's my problem, see, I probably don't remember half of the names of the girls I've all seen. I have to stop and think of yours once in a while. That's what's so disgusting. I feel so good, but still, you can't remember these things that you'd like to know. I should know. The faces you know.
So Bessie, we met each other in May of this year. Remember meeting you?
No, the faces are remember.
I was the one who put you through the memory test a few months back. Okay. Well, what we want to do is take you through some of those same sorts of tests again today, just to see how things are going for you. Fair enough? What is this thing? What's it used for? Very good. For this next part, I'm going to read you a list of words. I want you to listen carefully, and when I'm finished, I want you to tell me as many of those words as you can remember. Here we go. Cloud, fish, pink, dentist, ladder, chicken, banana, telephone, truck.
Okay, don't freak out. That's a lot of words. So don't worry. I've heard the words 20 times. I still can't list the words. Okay, which of those cognitive domains did you notice in Bessie? So she's 87. She's very mild, right? But what did you notice? So it's mostly memory, right? And you can tell it. So what's the signal that she's telling you it's a change? She realizes it. She now has to look at the recipe more. She can't remember all the folks in the harmonettes. Mm-hmm. What else did you notice?
She can remember why the marigolds were there.
Right. Yep. She had another cognitive domain kind of at the end when the doctor was doing the testing. She had
Recognize the object and what it did.
word finding. She could not come up with the word calculator. I had this exact experience with my mother last month. So she knows what it is. She knows what it does. She cannot come up with the word calculator. So word finding is very common. Now, of those list of the instrumental activities of daily living, the IADLs, do you think there's anything she couldn't still do? We saw her cooking. She could that pie's probably pretty good. She just has to do it in a different way right now. She's still driving. Yeah, probably cell phone's out, right? So learning something new like a cell phone would be hard because that's new information. All right, now this is Josephine. She is 10 years younger than Bessie. She's 77. She lives on a farm in Minnesota, and she's had all her Alzheimer's disease for 5 years. So look for those different cognitive domains in Josephine.
You hear about it on TV or in the newspaper about, a year-old man lost in, miles away from home. 5 years later, they're looking for him. All different, I hear that. Sometimes when my swimming group came and we saw this fence up basically the whole perimeter of the fence, and where was it? Can I hear you? What happened? What happened? So I'll hang it up on this. Oh, do you want to hang it up? This week would be fun, and the whole thing of talking about putting the thing. Oh no, we gotta do the cat food. No, you can't eat that. That's for the cat. Little vignettes, might say, that I find around the house, and I take pictures of them. It shows you the little vignette that she's made there. Something I got a cool opportunity here to see.
Pretty impressive, huh? All right, so what do you notice about Josephine? Which of those cognitive domains? Yes?
I don't think she recognized her daughter.
Yeah, she may or may not. It's really hard to tell. Yeah. Absolutely, because she has so much language impairment, right? She really has a lot more language impairment than a lot of folks in the moderate stage. Now, if I keep rolling the video, she ends up putting a rock and a pebble in her mouth. They're out on the trail, and she picks it up and pops it in her mouth. And when the daughter's trying to get it out, she can clearly say, "No, I don't want to." So she's got some language in there still, but she's got a lot of word-finding language. What else?
That kind of sound, is that typical, or is that very unusual?
She's just no longer able to communicate via words. All her brain can do now, for all we know, she's saying something
But she needs to do it
constantly. Yeah, I've seen that. And the wandering. Absolutely. Yes, sir.
She seemed obsessed with running out of wherever she was.
Yeah.
The gate, the fence,
Right.
the lock.
Right. So the constant pacing, wandering. Right. And then you saw kind of the judgment. Okay, I'm going to eat the cat food. Later, I'm going to pick up the kind of reasoning. What did you notice about this caregiver? We didn't get to meet Bessie's caregiver. It's another daughter, but Bessie's still living alone. This daughter has moved into the farm, into Josephine's farmhouse to live with Josephine. What were some of the things you noticed about the daughter? She's very patient, yes. Patient as Job. What words did she describe kind of what she's experiencing? Fear. I'm experiencing that for my mother, right? Yeah. It's very normal. Frustration. How did her community help them out? Did you hear that at the beginning? They fenced it in, right? So, how do we shrink this down again? This one? Escape, that's right, thank you. Yeah, so one of the take-home points for today is that we're all in this together, and as caregivers, we can't do it by ourselves. And so this community really stepped in and helped this family with building the fence. And that's one place the church can step in, and we can also kind of step in and help each other. And so we'll get to a little bit more of that in a minute. So what is the progression? How do people typically progress through Alzheimer's disease? Most people will never get dementia or Alzheimer's disease. If we are going to get Alzheimer's disease, this is kind of the typical progression. So this kind of preclinical phase. Here we go. So we all kind of have these normal changes that are very slight as we get older. Folks who will eventually develop Alzheimer's go through these early stages, this kind of preclinical, or MCI is the mild cognitive impairment. This is where there starts to be a little bit more noticeable change, maybe usually with the person themselves notice it, or maybe a family member, but it just doesn't progress the way dementia does. So my mom kind of stayed in this stage, this mild cognitive impairment stage, for 7 years. I know this because she was getting annual memory testing. And I know this because we were watching very closely. And it's where she just started having a little bit of problem-solving difficulty. So it was a change from her baseline, but it didn't progress. She could still function throughout her day. It was very, very subtle. And she just kind of stayed there for 7 years. So some folks will get this mild change and kind of stay there forever. And some will eventually, over 3, 4, 5, 6, 7 years, 8, 10 years, further decline. Remember, to be actual dementia, you've got to have a change that impacts your functioning. And so in the mild stages, that's when you notice the IADL changes. And as patients slowly decline or have more changes in their brain, when folks start having trouble with those basic things, the bathing, dressing, toileting, eating, transferring, now we're going into the more moderate and eventually into the later stages. Does that make sense? This time period can be a decade or more. My grandmother probably did this over 15 years. Now, if someone has sort of new vascular disease on top of it happening, then that can sort of speed up the timeline. It's a very gradual change. So families really can't point to a specific date or month or year. It's just more, well, we noticed over the last year X, Y, and Z. Does that make sense? Yes, sir.
They talk about early onset,
Uh
late onset. What's the differentiation there?
There's a very kind of rare genetic defect where families will get Alzheimer's in their 40s. That's very early onset, very rare, very atypical, but those families are being studied to help sort of solve the problem for the rest of us. The more typical time frame in here, 60s is kind of early, but we see it 70s, 80s. Actually, sort of the longer you live, the more likely you're eventually to develop dementia. It just means that you did not develop cancer or heart disease or diabetes or something that took other folks at a younger age. Remember, all the organs are going to slow down and fail at some point. So, you know, Bessie is 87. So by 87, 30 to 50% of folks are going to have mild dementia anyway. And at some point, you kind of get into, to me, you get into the philosophical question, well, if the majority of people have it, isn't it now normal, right? So basically, the longer you live, 80s, 90s, get to 100. I meet folks 100 who still have no changes in, significant changes in cognition at all. But the likelihood just goes up as we get older. So the take-home message here is we are not alone in this journey. There are millions of people with dementia and even more caregivers out there. So I wanted to show another DVD. This is some training clips that we used to train of our own staff of how to interact with patients. This is for folks more with maybe moderate or advanced dementia, how to kind of interact with them. Before we kind of switch over to that, any other questions? Yes?
There's a fair amount of this that seems to assume some standardized or normal environment. I've got a friend with early onset who worked with a chemical company, and has anything been determined that sometimes working in those sorts of environments amplify the likelihood or increase the likelihood of some kind of thing?
Yeah, it's a great question. So it's possible that if your brain has had insults along the way. So we don't know for sure about certain chemicals, or I don't know for sure. If you have had a history of head trauma, so my mom was thrown from a car and had a concussion when she was in her 30s. So that's another risk factor. Now, you're still more likely to not get dementia, but the brain kind of only has so much reserve capacity. And if you already have some limited reserve capacity because your brain took some other hit from like strokes or perhaps a chemical or a concussion or a brain injury, then when the Alzheimer's disease starts kicking in, you're probably going to see it sooner because the brain didn't have as much reserve capacity to begin with. Does that make sense? Yes, sir.
It looks as though, from what we've seen so far, that dementia, particularly severe dementia people, the only kind of help they can get is somebody assisting them or guiding them or protecting them. But I don't see any evidence yet of medical involvement other than testing. Is there nothing on the horizon yet in terms of addressing this with some kind of intervention to prevent it getting any more advanced?
Right, great question. So while we're setting up the DVD, the medicines we have right now, there's two classes. One is a class that Aricept is in. That's probably what most people are familiar with. That's what my mom is on. None of the medicines right now actually interrupt the disease process, the process that is killing off the brain cells. The medicines we have right now, remember I showed you the forest and the trees, and the information travels from tree branch to tree branch by chemicals that go across that gap. As part of the normal process, the chemical is released in the gap, and then eventually the chemicals are sort of reabsorbed and broken down, and then sort of recycled. As you have fewer and fewer tree branches, you have less and less of the chemical. Does that make sense? It's the chemical that's transmitting the information. The medicines we have right now slow down the breakdown of the chemical. So it allows the chemical to hang out longer, to have time to find another cell out there to communicate information. So by doing that, the goal is to slow down the symptoms of the disease. So it's not stopping the killing of the cells, of the brain cells. It's allowing the chemical that transmits information to hang out longer so it can find another brain cell to then transmit information to. Does that make sense? So eventually, over time, there's just not enough brain cells left for the chemical to find a brain cell, and that's when the medicines have less effect on memory. So in those kind of research studies looking at Aricept type of drug, and I've seen this in patients can get somewhere from 6 months, I've had families say a couple of years of sort of stabilization of the symptoms of the memory loss and of the dementia. The goal right now, and we don't have any yet, the goal right now in research is to try to find drugs that actually stop the disease process itself. And one of the reasons they're having trouble is they're still trying to figure out the exact disease process. It's got so many different components. It's got a vascular component, an inflammation component, an abnormal protein buildup component. For decades, when I was in school, they were trying to get at the abnormal protein, and none of that sort of panned out. Now they're trying to get at the inflammation component, even with IV infusion medications, trying to hit people in that MCI bucket or the very early bucket, where you go and you get a monthly IV infusion of a drug that basically sort of shuts down your immune system so it turns off inflammation, and can that actually interrupt the disease process. So there's those kinds of research studies, and actually in your resources handout is a place where you can look into those research studies at WashU and sign up, whether you don't have dementia at all or whether you have mild cognitive impairment or mild disease. There's all kinds of research studies out there. So.
For duty works within like 5 days.
Okay, great.
Misplacing things.
Okay, yeah.
Whether it was
Right.
clothes, pasta,
Great.
and garden tools, it just
You noticed a difference.
went back to normal.
Great,
For
right.
about 5 years.
Okay,
And
good.
Started seeing it reoccurring.
Yeah.
And that's when we need to switch. But in our case, I've heard a lot of people say, well,
It didn't work.
anything.
Right.
In her case, it was amazing.
That's a great example. So what was happening is that chemical was hanging out in her brain longer and able to work, able to transmit that information. Very good. Module 2. Yeah. Thank you so much. See, I knew I needed the. So this is a video from Teepa Snow, and I can show you. I've got a slide in here that has her website if you're interested. She's an occupational therapist who started with the somewhere in North Carolina, East Carolina Alzheimer's Association, and she's now known nationwide, and she trains healthcare providers in how to communicate and interact with patients with dementia. So lots of materials. This clip, if it doesn't show, I can role model it. It's kind of going to get at how to, when you have a patient who's more moderate or even severe, how do you even sort of approach the patient so we can create an environment where the patient will work with us or not be frightened or become agitated or scared.
It's almost like working with 2-year-olds.
Yes.
I mean,
Yes.
so like that one daughter, when she said, "Can I have this? Can I have this?"
Yes.
Okay, you take it.
Yeah.
You just say, "Okay."
Yeah, exactly. Exactly. I can role model with you. Oh, here we go.
I'm Alan Watson, Executive Director of the
That's module 1, I think.
Alzheimer's Association. We are dedicated to providing.
All right, yeah, that's perfect.
So far, we've talked about dementia and Alzheimer's disease, and some of the symptoms and behaviors you're typically going to see. These folks will present unique challenges to your caregiving. What we want to focus on now is building your skills, teaching you ways to be successful when you work with people with dementia. What we're going to do now is work on some skill building. And Daddy, I'd have you come up and join me in the chair. As we've sort of given you the hint, the big change that you're going to have by the end of the day is how you interact. And we're going to start off with your approach. because how you approach people makes a big difference in what happens next. One of the first things that we sometimes do with people with dementia is we come up and behind them and we just touch them. Okay, or let me just do something for you here. That is how this works for you. Okay, you okay with that? All right, you doing all right? Not bothering you at all? Not yet. Little, and what would you feel like doing? What do you sort of feel like getting away? Okay, human beings are pretty much hardwired to protect themselves, and one of the things we don't like is when things come up and we can't see them coming. It makes us very uncomfortable. Okay, and it actually elicits an automatic reaction. Okay, it's called flight, fight, or fright. Now, imagine instead of being in a nice, comfortable classroom, we're in a dark part of town, late at night, you've lost your keys in your car. You start to hear and feel something come up behind you then. Now what? Now you just want to run, okay? And some folks tend to be more flight people, fight people, or fright. If you're a fight person, what's going to happen? You're going to turn around and get popped or yelled at, that kind of thing. What if you're a flight person? They're going to take off, okay? And what if you're a flight person? You totally freeze up. And you will see people literally, when they're approached and they have dementia, they'll latch onto a chair and they can't let go. And that's flight. That's just your fright. So, let me do one more thing here. Hey, Thaddeus. And the reason I don't is I'm too close. I'm at a funny angle. My eyes are tipped to the side. And it's really difficult to sort of figure out what's going on here. When might this happen? When can you see this could happen? Wheelchairs. You come up behind people in wheelchairs? Yep, we're out. At a dining table. Yeah, that happens a lot. I recognize Thaddeus and I say, hey, Thaddeus, how you doing today? And with lack of impulse control, I might get myself in trouble. So the first rule on approach is always come from a good visual way. Always approach where they can see you. Give them a chance to know you're coming. So you want to come from the front so that they know you're coming in. Now he can process the information, sort of figure out, oh, there's somebody coming. If you're capable of doing that, your brain's still able to do that. Now pull your feet back, Thaddeus, for this next one. Get ready? Not ready? Just you're ready. Okay. He was ready. What happened?
We all got away back.
We all got away back instantly, right? Coming in too fast, not giving him time to figure out what's going to happen, results in, Thaddeus already told us, he tends to fly. He wants to get away. So what was he doing? Trying to get away. Now, somebody who tends to be a fighter, what might I do? Push me back away or grab me and try to shake me or do something to me. Who started it? I did. Okay? I came in too fast. Now, I'm not saying that caregivers race up, but in the mind of somebody who is damaged with Alzheimer's disease, it feels like you're coming in really fast. The other thing I do is, okay, Thaddeus, let's get those shoes off. Come on, hold your Thaddeus. Come on now. Let's get your okay, because I know what I want to have done, and I never check in with Thaddeus and make sure he knows what I want to do. And so what happens is conflict, because I came in too fast. So the rule is come from the front. Okay? Second rule is go slow. And it's 1 second, 1 step. So it's 1 1,000, 2 1,000, 3. It gives him a chance to figure out what's going on. Now, you come from the front, you go slow, still have an opportunity to move it. I'm going to stand right in front of him. And I'm going to smile real big. How's that working for you, Sandy? Kind of awkward. Yeah, what about if I do this? How about if I do this? Yeah, because it takes you back to those days. This dance is actually called confrontational stance. Think about it in real life. When do you use this?
When you're disappointed.
When you want to get in somebody's face, you really are like trying to gain intimidation. Is that what we want to do with people with dementia? No, because it's going to call that kind of response that we don't want to see, which is the anger, the lack of impulse control. So instead of getting right here in confrontational stance, I want to move to the side. Feel different?
Yeah, you're more kind of where I can deal with you.
What if you don't like what I'm saying? What could you do? Yeah. This stance is called supportive stance. four things. Now, I want to maintain arms reach. I don't want to be like this, because we're back to the same old problem. Arms length, so that I could reach out like this. He feels a lot more comfortable with that. I'm less likely to get that automatic reaction. So to put it together so far, come from the front, nice and slow, and come to the side. Feel better? You sure? The other thing you'll notice, if he smiles, did that mean he was happy? What was it? Yeah, that nervous kind of, you'll see people with dementia do that a lot. They'll smile and doesn't mean they're happy. They're anxious and nervous, and they're trying to figure out how to make this work. Now, here I am to the side, looks pretty good, but I want to get to eye level, right? What do you think? Big plus, big plus. So bending over to get down doesn't work. What does work, however, and how's that feel? Who feels like they're in control? Who's in control? Yeah, but did I actually give up anything here? But I did because that Thaddeus feels in control now. Who's more likely to cooperate with me? Yeah, absolutely. I still have one more cancer over here, and I grab hold of it. Come on, let's go. What's the automatic reaction? Pull back. I want to make my job more difficult because it's not hard enough. What I really want to do is think about how can I get him to work with me. So instead, what I'm going to do is offer my hand out and let him take my hand. Okay. Who's more likely to cooperate with me? Somebody who offers his hand or somebody who's just patient? Offer their hand because that signifies an interest in participating. So if I put it together, it's going to look like something like come from the front, go slow, get to the side, get low, offer your hand. Now I'm going to call the person by name and make sure he's connected with me, he knows who I'm talking to, he knows what we're going to do. That is. Do I have one? Show your fear.
Actually, in Alabama, that works, okay. Does that make sense? So one of the most common things I see in healthcare is not that approach, right? So in hospitals and nursing homes and clinics, the workers are in a hurry, and they're being sent in to take a blood pressure or get a weight or put the shoes on, and it's just too fast, it's confrontational, it's right in front, and then they start to get the pushback, and then they get the "you're not listening to me," and then who needs to change the behavior. So that's the opportunity for interacting with folks. Again, we're talking about more in the moderate to advanced diseases. So in our videos, Bessie, she doesn't need that approach. She's driving and functioning in the community, but Josephine maybe, especially if Josephine's kind of having a rough day and it's time to maybe go to the bathroom or get ready for dinner or something. So I use this approach all the time in the hospital. It works perfectly. And the other thing is just approaching folks with a smile. And now I'm in the hospital setting, so patients are already in unfamiliar places and frightened and scared, and people are doing stuff to them all the time. So just someone who's coming in slowly from the side, kneel down, extend a hand. Even in advanced diseases, we kind of always have been shaking hands and responding to smile. That works like magic every time. And then from there, there's other tips. We don't have time for it today. But then when actually communicating, and this is in your handouts, for patients who are more moderate or advanced, if you want them to do something, you want to communicate it in short sentences with 1 or max 2 steps at a time. So you don't want to do that beautiful approach and then say, hey, we're going to get up, go get dressed, go change clothes, and then go out to dinner. So you've done this beautiful physical approach, and there's no way they can retain all those steps. So you can do that physical approach and then say, Brian, let's stand up. And then the use of visual cues to help Brian understand what you're saying to stand up. So those steps, simple 1-step commands, 2-step commands, if you have something you want the loved one to do and that's going to take 4 steps, you're just going to break it down into like 1 step at a time. Does that make sense? All right. Let's get back here. So I wanted to kind of finish up this session, this part, with some caregiver resources. So you'll have this in your packet, but if you just Google Teepa Snow, you'll get her website. There's all kinds of DVDs and training materials. Some of her videos are YouTube, so those would be free. But I've given you her information as a resource. These are some of the tips we talked about. Some she showed, and some we talked about using the short, simple sentences, simple steps, speaking clearly.
Could you back that up here so
Yeah.
we can see what the email is, please?
Oh, sure. Can you see that there? It's just teepasnow.com. Absolutely. Teepa, that's her first name. So this is a little bit about what she demonstrated. The other advantage to kind of coming to the side and getting down on one knee is you're maintaining eye contact, because some folks may have also had some changes in hearing, so they're actually reading your lips to understand what you're saying as well. Or if they've had changes in vision, you don't want to be talking from across the room, so it's hard for them to see you. This is another key tip. I'll even see healthcare workers do this. They'll walk into the nurse or the doctor will walk into the room and say, "I'm Kelly. Do you remember me from yesterday?" Well, you're just reminding them that they don't remember you from yesterday. So when I'm making rounds, I reintroduce myself again the next day, and I'll say, "I'm Kelly. I'm with one of the geriatric medicine doctors. I was here yesterday, but I know you've met a lot of people since you've been here," right? So kind of normalizing that they may not remember me. And then turning negatives into positives. So instead of saying, "Don't go there," "Josephine, don't go down that road," it's, "Josephine, let's go over here." So anything where you're about to say don't do, try to turn it into the alternative that you want them to do. Okay? So don't eat that, but let's come over here and play with this or something like that. Does that make sense? Yes, sir.
Kind of reminds me of how we deal with children.
Mm-hmm. Very much. So life is a circle. Yes, and it's just coming full circle. That's right. It's just coming full circle faster for some of us. And again, if we're living long enough to develop dementia, it means we've survived or not been given heart attack or cancer or something else. So what's in your packet is a little bit of information about caregivers. Now, I share this because I suspect most people are here because they're a caregiver. And the most important take-home message is you have to take care of yourself. Okay, so caregiving, trying to do it alone is hard work. Here's kind of some national statistics of how many hours folks are spending caring for a loved one. And again, you guys aren't getting paid to do it. I get paid to do it. But I'm already even experiencing up to close to 5 hours a week for my mom. And I'm doing that across 3 states. But just, the time and hunting down a doctor and trying to investigate the power of attorney and, do they have frequent flyer miles? All that is now things that they can't do for themselves anymore. So the time does start to add up. I'll also tell you there's no greater privilege or blessing for me than to do that. So things can be hard and a privilege at the same time. Yes, sir.
National Geographic this last week had a program on Alzheimer's.
Oh, great.
I thought was really
Great.
discouraging.
Discouraging?
Because
Okay.
they showed a couple, and she was required eventually to be in a nursing facility,
Mm-hmm.
and they were talking like $10,000 to $12,000 a month.
Mm-hmm.
And within a few months, he had sold their home, their children had
Mm-hmm.
exhausted all their funds,
Right.
and now they were trying to get on some kind of Medicaid.
Right.
But the problem was there was a waiting time, and there's this gap of unfinanced. Do you have any experience with that?
Yes.
How it can be handled so that, you don't end up going to the, county courthouse?
Absolutely, absolutely. If you don't mind, hold on to that.
Yeah.
Absolutely, because we're going to finish up with that discussion for sure. Yes.
I just have a comment. I was looking at how you communicate with folks like that, and I was thinking about the gospel.
Right. Yeah.
In our
Thank you.
hearts as believers in the church, thinking and marveling at how, even for us folks who have dementia, that God has sent verses from the side.
Yeah.
Human being.
Yeah.
He gets down on his knees, and in fact, he goes to a cross. He puts, divine language in English, which is ridiculous. I mean, that's the kind of thing from the heart outward melts our hearts and enables us, to do those things naturally out of gratitude for what God's done for us.
Yeah.
So, I just want to add that as a
Thank you.
thing.
Thank you. Yes, sir.
In our hospice organization, we have a lot of different ways of reaching out to folks that are in institutions. Pet therapy is one.
Mm-hmm.
But one of the things I do that seems to be really helpful is playing hymns.
Yes.
Old hymns that they're familiar with
Yes.
on the guitar or banjo
Yeah.
and singing along. And not even singing sometimes, just playing the melody, and that stimulates some kind of remembrance.
So I'm glad you brought that up. So it's very well recognized that we can remember more when it's in song or set to music. It's a different part of the brain. It's kind of like when the old schoolhouse rock taught us the preamble to the Constitution. We the people in order to form. Like I could sing that, but I could not just recite it. I can sing a song, but if you ask me just to recite the words to the song without the tune, I can't do it. So this is very common in dementia patients, even more so. My grandmother, in her very late stages, really could not recognize who we were, could not really communicate anything about what was going on. But when the pianist came and sang the old hymns, she could sing every word. So there's definitely something therapeutic in music. And you saw Josephine was an artist, is an artist. The artist is still there in Josephine, right? It just looks different, but she's still an artist. So artists in medicine, we have this at UAB, where these folks can express themselves through artwork, even if they can't find the words, they can still express themselves through artwork. So just wanted to share a little bit about the importance of reaching out for help. So right here in a room is a room of fellow caregivers, the support group. Maybe at the break you can meet someone you haven't met. And we want to try to prevent some of these effects that can happen to caregivers, especially this last one, not being able to see your own doctor or getting your own medicines. Remember the story we started with? So this disease my grandmother's disease had a profound effect on my grandfather, and he actually ended up passing away before she did. Here's just a little lightheartedness, and then we'll get to the financial questions. All right, so I play that so you'll remember it, right? Put your oxygen mask on yourself first so you're able to care for your loved one. Does that make sense? All right, so the last in your handouts are the various support groups and resources, or the two primary resources out there at the national level, which can help you get down to the local level. So the first is the Alzheimer's Association. This is the link to actually the St. Louis chapter, but if you just Google Alzheimer's Association or just look on the internet, It'll get you to their website. There's a 24/7 helpline you can call day or night with any question or issue that you have. And then they will help guide you to the right resource. Probably the most important thing is a support group. Does anybody belong to a dementia support group of any type? Do you mind sharing about?
We have one there at
Great.
7 people every day.
And how is that helpful?
Hearing others with similar problems.
Right. Exactly. So the first thing I've done in the last 6 months when my mom's been officially diagnosed is reach out to all my friends who are experiencing the same thing. And even though I've been taking care of dementia patients for 15 years, I'm telling you, I'm learning things I've never learned before. So you guys are the experts, okay? And you have tips that you can share with others who are experiencing this as well. So the Alzheimer's Association is a great resource. And a family. Right. Yep, absolutely. Right. Great. Thank you for sharing that. It really is. So I really want folks to walk away just knowing that you're not alone. I also have seen and experienced myself, God has a special place in His heart for these patients and their caregivers. I have no doubt in my mind. We live in a fallen, broken world. This is part of that journey. But there's some uniqueness about this experience that I know God cares for these folks and for us deeply, and I'm experiencing that. So just more information about, so from there, this link here gets to their specific web page for caregivers. So, and you have this in your handout, and on your reference handout, and in your book is tons of websites around dementia care and palliative care as well. And then the Family Caregiver Alliance also has videos and materials for caregivers. And for those of us who are not caring for a loved one with dementia, it's kind of our role to be the helpers for the helpers. And that's really where the church can step up. And this kind of leads into the financial question. So the healthcare system in the United States is not geared to provide the support that these patients need. So Medicare does not cover to go and live in a nursing home. Medicaid varies state to state. So you need to find a social worker or someone who can kind of walk you through Medicaid in your specific state, who qualifies for Medicaid. Medicaid does pay for someone to live in the nursing home, but you essentially have to spend down your life savings to be able to qualify for Medicaid. And I see heads nodding. Some of you have probably been through this part of the journey. Most people whom I'm currently seeing who are experiencing dementia do not have long-term care insurance policies because those just really weren't out there 30 years ago. That's another type of coverage that's out there, and you'd have to really investigate what each different policy provides. But that's another type of insurance that you purchase that provides kind of help for those IADLs or even those basic ADLs that could be delivered either to cover you to go to a long-term care facility or even to get help in your home. So to have that kind of additional nursing home type care to come into the home, some long-term care insurance policies cover that type of service. Does that make sense? But they're all different, and you really got to do your homework and get an elder law attorney or someone to help you kind of look at those options. Yes, ma'am. Yes, exactly. So each state has its own waiver programs. Can you speak more about that? Perfect. And that's very different in every state. So your go-to person would be a social worker, an elder law attorney. to really find out what are the options for me or my loved one through Medicare, Medicaid, Medicaid waivers, long-term care, and then other services that are out there that provide help in the home but are private pay. So sitter services or aid services. And then if someone is a veteran, the veteran does have very nice benefits to provide this extra type of care that non-veterans don't have. So if someone is a veteran, be sure and get connected with your VA and find out what options are there. So you almost have more help if you're a veteran than not. Was there a question over here?
Well, I just started just recently on the internet, I can't remember where, but saying that the long-term care insurance is kind of being denied to people with mental problems now.
So you have to purchase, so it's a gamble, right? So you have to purchase it before. So someone like my family history, I'm going to purchase long-term care insurance at some point because I have a very strong family history of Alzheimer's, and so I'm going to plan that I'm going to get it. So it's like any kind of other insurance policy. You're paying for something that you might never need, but if you need it, you kind of might want to have it. But yeah, once you've already tipped over, so like my father was too old to get the policy, but my mother, we knew my mother was headed this way, so we got her the policy before she was diagnosed. Yes, ma'am.
Yeah, hanging on to that. It was my understanding, Carrie, the chaplain who spoke last Sunday, if I understood him right, those policies are not even being offered anymore because they detect dementia, but such an epidemic of Alzheimer's and all of the babies and everything. So if I understood him right, you can't even purchase that anymore.
There are still companies out there that sell them. My company's trying to sell me one.
Oh, really?
So they're out there, and also that industry is only going to be able to support so many because the dementia will be, it is like an epidemic coming out. It's just because of the increase in the population. So it's that very kind of, it's an unknown. Am I ever going to need it? If so, the younger you purchase it, the more months you're going to pay for something you may or may not ever need. And there may come a time when the baby boomer volume hits the point where the industry can't even offer that as an option. So I think it's an opportunity for the church to help out too. So one real life example, and then I want to give you guys a break, and then I'll be up here in between too, is at UAB Hospital, our pastoral care department has developed a program they call patient support teams. So they'll get referred, so it's for patients, and the patient doesn't have to have dementia, but a lot of them do. It's patients who need more support in the home with those IADL type things, cooking, cleaning, going to the grocery store, getting to the doctor's office, doing laundry, where insurance companies don't pay for that kind of help. But that's the kind of help they need if they want to be able to stay in their home and live independently. And that may be folks who live alone, or maybe folks who live with a family member, but the family member's at work all day. So the pastoral care department will refer patients to them. The chaplain will work with the patient's own network. So is that network neighbors, church members, family members? So a lot of these folks have folks in their life. It's just a matter of getting them coordinated into a team with like a team schedule to help perform the tasks that each team member feels comfortable in performing. So you might have someone say, well, I can mow the lawn every other week. I can do that easy, but I'm not a cook. I have somebody else say, well, I can provide transportation to the grocery store and make sure we get there, get food, and get back. So the pastoral care department puts together this team of support from the patient's own network. There's no charge then. The patient gets the services they need. It just needs sort of a leader to get it going, and then each team is assigned kind of its own leader who kind of keeps the schedule and the calendar and keeps the program running. Does that make sense? So we're really going to need each other to fill in this gap that our healthcare system just does not provide.
So is there a model for that? Like you just said? Like, is there a go-to model? Is there a church around here that's doing something like that?
Doug, are you aware of a church that's doing kind of that patient support team?
Well, no. This is a huge gospel opportunity. Huge. Again.
So I could, yeah, go ahead.
And not just the
Right.
of people, because people are at their most spiritually receptive when we're suffering, struggling. So it's holistic care.
Yeah. So that's kind of one of our last takeaways before our break, is we really want folks to walk out of here with at least one action step, either to take care of yourself or to help do something to help care for a dementia patient. Just one action step. And it's something like, that's a pretty big action step, but it's an action step, something like looking at how do we form one of these teams. So my parents could use one of these teams right now just to mow the lawn. Just something around that, just coming to mow the lawn every other week would be a tremendous help for me and my family.
We do that here on a case-by-case basis. The deacons take the lead on that. And so there are several, Jack Delagamba has a team. There's others who have teams, and those get organized by the deacons, and that's exactly the model they use. You get a group of people, and one of them's in charge, and they can always come to the diaconate for additional help, additional resources. I mean, we have a number of people with special needs that are, but at this point, it is on an ad hoc basis with the diaconate overseeing.
Yeah, and you make a great point. This applies not just to folks with dementia, it's any sort of hardship is a great word. All right, so I wanted to give you guys, you've been sitting a long time, so maybe like a 15, 20-minute break, and then we can come back, see if there's any other questions around this that we didn't hit on, and then we're going to finish up with the palliative care hospice discussion, and then anything else you guys would like to talk about. All right, thank you so much.